The illusion of a motor disorder. It looks like Parkinson's again. The patient presents with slowed movement, mild rigidity in the wrists and neck, reduced arm swing, and a gait that has become cautious and narrow. And Parkinson's disease becomes the default assumption, because statistically it is the most common cause. The neurological exam reinforces that assumption. Finger tapping is slow. Rapid alternating movements are reduced in amplitude. Muscle tone shows resistance to passive motion. The diagnosis appears straightforward. Yet even during this early visit, subtle features sit beneath the motor surface. The patient describes lightheadedness when standing from a chair. There is a history of urinary urgency or retention that began months earlier. Episodes of near syncope have occurred, but were attributed to dehydration. These details are recorded, but not emphasized. They do not fit the motor model of Parkinson's disease, and so they are treated as secondary complaints rather than central signals. Levodopa is prescribed, as it would be for Parkinson's disease. If dopamine depletion is the core mechanism, improvement should follow. In early multiple system atrophy, a transient or partial response may occur in some cases, which can sustain the initial diagnosis. However, the improvement is incomplete. Gait remains unstable. The patient continues to report dizziness when rising. Blood pressure readings reveal significant drops upon standing, but these findings are not yet framed as structural autonomic failure. They are considered complications rather than defining features. The illusion persists because Parkinsonism is visible while autonomic dysfunction is invisible. Blood pressure stabilizes without conscious awareness. When this system begins to fail, its breakdown is subtle until a threshold is crossed. Lightheadedness appears before collapse. Urinary difficulty precedes complete retention. The signs are present, but not yet catastrophic. Multiple system atrophy begins not as a cardiac disease, but as a movement disorder that conceals systemic instability. Alpha-Synuclein pathology is already accumulating within oligodendrocytes in regions far beyond the striatal pathway. Brainstem autonomic nuclei are degenerating. Sympathetic pathways descending to the spinal cord are weakening. The patient experiences these failures as dizziness, urinary dysfunction, or erectile dysfunction, but the heart itself has not yet been recognized as vulnerable. The patient and clinician both anchor to the diagnosis that promises gradual progression and medication responsiveness. The alternative implies a faster and more systemic decline. During this stage, cardiovascular control begins to destabilize. Yet each episode reflects a structural weakening of autonomic integration within the brainstem. The nervous system that regulates heart rate, blood pressure, and vascular tone is failing in parallel with motor circuits. The motor symptoms bring the patient to the clinic. The autonomic symptoms quietly define the prognosis. The illusion of a localized motor disorder delays recognition that the disease extends into the very systems that stabilize circulation and sustain life. Only later does the pattern reveal that those complications were not peripheral. They were central. The heart has always been part of the story, not because it is diseased independently, but because the neural systems that control it are degenerating from the start. What autonomic control really means? The invisible nervous system. To understand why multiple system atrophy carries cardiac death risk, the architecture of autonomic control must be defined precisely. The heart does not regulate itself independently. Every beat is modulated continuously by neural circuits embedded in the brainstem and spinal cord. When these circuits fail, the heart becomes unstable, not because it is structurally diseased, but because its regulatory command system has deteriorated. At the center of cardiovascular regulation lies the nucleus tractus solitarius within the medulla. This structure receives sensory input from baroreceptors located in the carotid sinus and aortic arch. Baroreceptors detect changes in blood pressure by sensing stretch in arterial walls. When blood pressure falls, reduced stretch decreases afferent firing to the nucleus tractus solitarius. This signal triggers a coordinated sympathetic response designed to restore perfusion. Blood vessels constrict. Heart rate increases. Cardiac contractility rises. Blood pressure stabilizes within seconds. This reflex arc is known as the Baroreflex and represents a critical survival mechanism in cardiovascular regulation. It allows a person to stand from a lying position without losing consciousness. It prevents minor fluctuations in blood volume from causing collapse. It maintains cerebral perfusion during stress. The reflex operates continuously, adjusting cardiovascular output in real time. Sympathetic output originates in the intramedullary columns of the thoracic spinal cord and descends from medullary cardiovascular centers. These sympathetic fibers increase heart rate by stimulating the sinoatrial node and constrict peripheral blood vessels to maintain systemic pressure. Parasympathetic control, primarily via the vagus nerve, slows heart rate and modulates beat-to-beat variability. The balance between these systems produces heart rate variability, an indicator of healthy autonomic integration. These nuclei fine-tune cardiac rhythm during rest and sleep. During inspiration, vagal tone decreases slightly, allowing heart rate to rise. This subtle oscillation reflects intact central autonomic control. It is not optional physiology. It is evidence of functional neural regulation. In multiple system atrophy, these brainstem nuclei degenerate early. Alpha-Synuclein accumulation within glial cells disrupts white matter tracts that connect autonomic centers to the spinal cord and heart. The Baroreflex arc weakens. Sympathetic activation becomes insufficient. Parasympathetic modulation becomes erratic. The heart continues to beat, but it does so without stable regulatory input. When a healthy individual stands, blood momentarily pools in the lower extremities. Baroreceptors detect reduced arterial stretch and signal immediate compensation. In MSA, this compensation is blunted. Peripheral vasoconstriction is inadequate. Heart rate fails to rise appropriately. Cerebral perfusion drops. The result is orthostatic hypotension, a visible manifestation of a failing baroreflex. Autonomic failure in MSA is not limited to blood pressure regulation. It includes impaired thermoregulation, reduced sweating, gastrointestinal dysmotility, and bladder dysfunction. These systems share neural pathways within the brainstem and spinal cord. Their simultaneous failure reflects distributed degeneration rather than isolated cardiac disease. Heart rate variability decreases as parasympathetic modulation declines. The sinus node becomes less responsive to physiological demands. Instead of adapting smoothly to stress, posture change, or sleep cycles, the heart rate becomes rigid and poorly modulated. This rigidity increases susceptibility to arrhythmias because the buffering effect of autonomic balance is lost. The critical insight is that the heart in MSA is structurally intact. Coronary arteries may be normal. Myocardial muscle may be healthy, yet the regulatory command center is disintegrating. The nervous system that stabilizes circulation is failing from within the brainstem outward. Cardiac instability is therefore neurological in origin. Autonomic control is invisible when it functions correctly. Its failure becomes visible only when thresholds are crossed. Dizziness on standing is not a trivial symptom. It is the first measurable sign that the baroreflex is weakening. Reduced heart rate variability is clinically significant and associated with impaired autonomic modulation. It signals parasympathetic withdrawal and sympathetic instability. These changes precede catastrophic events. Multiple system atrophy must be understood as a disease of autonomic integration as much as motor function. The degeneration of brainstem cardiovascular centers transforms the heart from a tightly regulated organ into one vulnerable to sudden instability. Cardiac death risk in MSA is not secondary. It is rooted in the destruction of the invisible nervous system that keeps circulation stable moment to moment. Multiple system atrophy shares a molecular protein with Parkinson's disease, but it does not share its cellular target. Both disorders involve alpha-synuclein, yet the distribution of that protein determines the trajectory of degeneration. In Parkinson's disease, alpha-synuclein accumulates primarily within neurons, forming Lewy bodies that disrupt intracellular function gradually. In multiple system atrophy, alpha-synuclein accumulates within oligodendrocytes, the glial cells responsible for maintaining white matter integrity. This distinction transforms the disease from a predominantly neuronal disorder into a system-wide failure of neural support architecture. Oligodendrocytes are not passive support cells. They produce and maintain myelin, the insulating sheath that allows rapid electrical conduction along axons. They regulate metabolic exchange between neurons and surrounding tissue. They stabilize long white matter tracts that connect brainstem nuclei to spinal cord and peripheral targets. When alpha-synuclein aggregates within oligodendrocytes, these functions destabilize simultaneously across multiple networks. In MSA, the pathological hallmark is the glial cytoplasmic inclusion. These inclusions are associated with impaired oligodendrocyte metabolism and compromised myelin maintenance. Axons lose efficient insulation. Signal conduction becomes unstable. Communication between brainstem autonomic nuclei and spinal sympathetic neurons deteriorates. The problem is not simply neurotransmitter imbalance. It is degradation of the structural pathways required to transmit autonomic commands. This glial involvement is believed to contribute to the more rapid progression observed in MSA compared to Parkinson's disease. When neuronal degeneration occurs alone, surrounding glial infrastructure may temporarily preserve conduction. When the infrastructure itself degenerates, redundancy disappears early. Axons cannot maintain stable signaling without intact myelin support. Autonomic fibers descending through the spinal cord become unreliable. The sympathetic pathways that regulate vascular tone rely on intact white matter tracts traveling from medullary centers through the spinal cord to peripheral ganglia. If oligodendrocyte dysfunction compromises these tracts, vasoconstrictive responses weaken. The heart receives delayed or insufficient modulation. Blood pressure becomes labile. Orthostatic hypotension is not merely a side effect. It is evidence of glial-mediated conduction failure. Parasympathetic pathways are similarly affected. Vagal fibers originating in the dorsal motor nucleus must transmit precise signals to regulate heart rate variability. Myelin disruption reduces signal fidelity. Beat-to-beat modulation becomes inconsistent. Heart rhythm loses flexibility. The sinus node receives erratic input rather than balanced control. White matter instability also affects respiratory integration. Brainstem nuclei coordinating breathing depend on intact conduction between medullary centers and spinal motor neurons controlling the diaphragm. Glial pathology compromises these connections, increasing vulnerability to respiratory irregularity and nocturnal instability. The same structural degeneration affecting blood pressure control also threatens respiratory rhythm. Unlike Parkinson's disease, where degeneration initially targets dopaminergic neurons in a relatively circumscribed manner, MSA distributes pathology across cerebellar pathways, basal ganglia, autonomic nuclei, and spinal tracts simultaneously. This widespread glial involvement accelerates functional collapse. There is less opportunity for network compensation. The presence of alpha-synuclein in glial cells also explains why dopamine replacement therapy produces limited benefit. Even if dopamine levels are restored temporarily, the conduction pathways that distribute motor signals are compromised. The disease is not confined to a neurotransmitter deficit. It is a failure of neural infrastructure. Cardiac death risk emerges directly from this distinction. When oligodendrocytes fail within autonomic pathways, the heart loses stable neural supervision. The sinoatrial node becomes vulnerable to abrupt sympathetic withdrawal or parasympathetic surges. Blood vessels fail to constrict appropriately during posture change. The Baroreflex arc cannot transmit signals efficiently. Instability becomes intrinsic. MSA is therefore not a variant of Parkinson's disease with added complications. It is a fundamentally different alpha-synucleinopathy defined by glial degeneration and white matter destabilization. The disease dismantles the scaffolding that supports autonomic integration. When that scaffolding fails, the heart operates without reliable command. The invisible progression of glial pathology sets the stage for cardiovascular unpredictability long before overt collapse. Motor symptoms may draw clinical attention, but the more dangerous process is unfolding within brainstem white matter tracts that regulate circulation and respiration. The difference lies not in the protein alone, but in the cells it destroys. Orthostatic hypotension and brain perfusion failure, the first structural warning. Orthostatic hypotension in multiple system atrophy is not a minor inconvenience. It is the first measurable failure of a collapsing cardiovascular reflex arc. When a healthy person stands, gravity shifts approximately 500 to 800 milliliters of blood into the lower extremities. Within seconds, baroreceptors detect the resulting drop in arterial stretch. Signals travel through the glossopharyngeal and vagus nerves to the nucleus tractus solitarius. Sympathetic output increases. Peripheral vessels constrict. Heart rate rises modestly. Blood pressure stabilizes. Cerebral perfusion remains constant. The entire adjustment occurs automatically and without awareness. In MSA, this reflex arc is structurally compromised. Degeneration of medullary cardiovascular nuclei reduces integration of baroreceptor input. Sympathetic pathways descending through the spinal cord conduct signals inefficiently due to oligodendroglial failure. Peripheral vasoconstriction becomes inadequate. When the patient stands, blood pressure falls precipitously. The heart may attempt to compensate, but the rate increase is often blunted because parasympathetic withdrawal and sympathetic activation are both impaired. The result is cerebral hyperperfusion. Blood flow to the brain decreases transiently but significantly. The patient experiences lightheadedness, visual dimming, or near syncope. These episodes are not random. They are evidence that the Baroreflex has lost its buffering capacity. Repeated episodes of cerebral hyperperfusion are associated with increased risk of syncope, falls, and secondary injury. Even brief reductions in perfusion strain cortical and subcortical neurons. Falls associated with syncope lead to traumatic injury. Fractures and head trauma accelerate decline. Orthostatic hypotension also stresses the heart directly. Sudden drops in preload alter cardiac output. The heart must adjust to fluctuating venous return without reliable autonomic modulation. In healthy physiology, sympathetic tone would stabilize, stroke volume, and maintain perfusion. In MSA, this compensation is incomplete. The myocardium experiences abrupt hemodynamic shifts that increase arrhythmic susceptibility. The failure is not confined to standing. Blood pressure variability becomes exaggerated throughout the day. Supine hypertension may coexist with orthostatic hypotension. When lying down, blood pressure may rise excessively because residual sympathetic tone is not properly modulated. This oscillation between extremes further destabilizes cardiovascular homeostasis. The absence of heart rate variability compounds the problem. Normally, heart rate adapts continuously to respiratory cycles and posture changes. In MSA, vagal tone is reduced and sympathetic signaling is erratic. The heart rate response to blood pressure drops becomes inadequate. Instead of a smooth compensatory tachycardia, there may be minimal change or an inappropriate rhythm shift. Orthostatic hypotension is therefore not merely symptomatic. It marks the breakdown of a life-preserving reflex. The Baroreflex is designed to protect cerebral perfusion and cardiac stability. When it weakens, vulnerability increases with every positional change. The danger escalates at night. During sleep, autonomic balance shifts naturally toward parasympathetic dominance. In MSA, This balance is unstable. Blood pressure may drop excessively during certain sleep stages. If combined with impaired respiratory control, hypoxia and hypotension can coincide, creating a critical environment for arrhythmia. Clinically, orthostatic hypotension often appears early in MSA. It precedes catastrophic events, but foreshadows them. Each episode of syncope or near syncope reflects a nervous system losing command over circulation. Medications and volume expansion may mitigate symptoms temporarily, but they do not restore the damaged neural circuits. The first structural warning of cardiac death risk in MSA is therefore not chest pain or myocardial infarction. It is the repeated inability to maintain blood pressure against gravity. The Baroreflex is failing. The brainstem is losing control. Circulation becomes unstable under conditions that were once trivial. Orthostatic hypotension is the visible sign of invisible collapse. It reveals that cardiovascular regulation is no longer automatic or reliable. From this point forward, the heart is operating within a narrowing margin of safety, dependent on neural circuits that are steadily degenerating. Cardiac arrhythmia risk in MSA. Autonomic instability of the heart. The heart possesses intrinsic pacemaker cells, capable of generating rhythm independently. The sinoatrial node is under continuous modulation by sympathetic and parasympathetic input. In multiple system atrophy, the degeneration of brainstem autonomic nuclei and descending sympathetic tracts removes the stabilizing balance that keeps cardiac rhythm adaptable and resilient. The risk of arrhythmia does not arise from coronary blockage. It arises from neural dysregulation. Under normal conditions, parasympathetic tone via the vagus nerve slows the heart during rest and sleep, while sympathetic tone accelerates it during stress or posture change. These opposing forces create heart rate variability, a marker of healthy autonomic flexibility. Variability allows rapid adjustments to maintain perfusion and oxygen delivery. In MSA, parasympathetic withdrawal and sympathetic denervation occur simultaneously. The heart loses beat-to-beat modulation. Rhythm becomes rigid, and rigidity increases susceptibility to destabilization. Reduced heart rate variability is one of the earliest measurable signs of autonomic failure. When variability diminishes, the sinus node becomes less capable of responding to physiological demands. A sudden drop in blood pressure may not trigger adequate tachycardia. Conversely, parasympathetic surges may produce inappropriate bradycardia. The buffering effect of neural balance is lost. Sympathetic denervation also alters ventricular repolarization dynamics. The QT interval, representing electrical recovery time between heartbeats, becomes more variable when autonomic tone is unstable. Prolonged or inconsistent repolarization may increase susceptibility to ventricular arrhythmias. While the myocardium itself may be structurally normal, the absence of stable autonomic input creates electrical vulnerability. In addition to rhythm variability, MSA patients may experience fixed tachycardia or inappropriate bradycardia. Without reliable vagal tone, resting heart rate may remain elevated. Alternatively, degeneration within parasympathetic nuclei can produce episodic bradyarrhythmias. These rhythm shifts may occur without warning, particularly during sleep when autonomic control is naturally dominant. The risk intensifies during physiological stress. Fever, infection, dehydration, or blood pressure fluctuations challenge cardiac regulation. In healthy individuals, autonomic reflexes compensate rapidly. In MSA, compensation is delayed or absent. The heart may not respond adequately to hypovolemia or hypoxia. Electrical instability becomes more likely under these conditions. Nighttime poses unique danger. During REM sleep, autonomic fluctuations increase. In MSA, where central control is compromised, these fluctuations can produce sudden shifts in heart rate and blood pressure. Combined with impaired respiratory control, episodes of hypoxia may trigger malignant arrhythmias. Sudden nocturnal death in MSA is often attributed to cardiorespiratory collapse mediated by autonomic failure rather than primary cardiac disease. Importantly, standard cardiac evaluations may appear normal. Echocardiograms show preserved ejection fraction. Coronary arteries are unobstructed. Troponin levels are normal. The heart muscle is intact. The instability lies upstream, within the neural networks that modulate cardiac rhythm. Pacemaker implantation may address severe bradycardia, but does not restore sympathetic tone or stabilize blood pressure variability. Similarly, medications targeting arrhythmia cannot re-establish Baroreflex integration. Interventions treat manifestations, not mechanisms. Cardiac arrhythmia risk in MSA is therefore neurologically driven. The heart becomes electrically unstable because the brainstem and spinal autonomic pathways have degenerated. The sinoatrial node operates without coordinated supervision. Ventricular conduction becomes vulnerable to fluctuation. Under stress, the margin of safety narrows further. This instability explains why sudden cardiac death can occur even in patients without advanced motor impairment. The degeneration of autonomic pathways may outpace visible disability. A patient may appear stable during daytime evaluation, yet harbor significant autonomic fragility that manifests abruptly. The progression toward arrhythmic risk in MSA is gradual but relentless. As glial pathology spreads through autonomic tracts, neural buffering disappears. The heart continues to beat, but it does so without the regulatory precision that once protected it from sudden shifts. The danger is not structural heart failure. It is loss of control. Nocturnal death and stridor brainstem respiratory collapse. In multiple system atrophy, cardiac death risk cannot be separated from respiratory instability because both are governed by overlapping brainstem networks. The medulla houses the respiratory rhythm generators that coordinate inspiration and expiration automatically. These centers interact continuously with cardiovascular nuclei to synchronize breathing with heart rate and blood pressure regulation. When degeneration spreads through this region, the integration between respiration and circulation destabilizes, particularly during sleep. One of the most alarming manifestations of brainstem involvement in MSA is nocturnal stridor. Stridor is a harsh, high-pitched sound produced by turbulent airflow through a narrowed upper airway. In MSA, it arises from vocal cord abductor paralysis caused by degeneration of nucleus ambiguus and its associated motor pathways. During sleep, especially in REM stages, muscle tone decreases. If vocal cords fail to abduct properly, airflow becomes restricted. Breathing becomes labored and inefficient. Stridor is not simply a sound. It signals impaired laryngeal control and compromised airway protection. Repeated episodes of airflow obstruction reduce oxygen saturation and increase carbon dioxide retention. Hypoxia and hypercapnia stimulate autonomic reflexes, but in MSA, these reflexes are already weakened. The cardiovascular system must respond to respiratory stress without stable neural regulation. Central sleep apnea may also occur. Unlike obstructive apnea, where airflow is blocked despite respiratory effort, central apnea reflects failure of the medullary respiratory centers to generate rhythmic signals to the diaphragm. In MSA, degeneration of the pre-Pingler complex and related medullary nuclei disrupts the automatic drive to breathe. During sleep, voluntary control is absent. If automatic rhythm generation falters, ventilation pauses. These respiratory interruptions impose sudden physiological stress. Oxygen levels drop. Carbon dioxide rises. In healthy individuals, chemoreceptor feedback rapidly stimulates breathing and increases sympathetic tone to stabilize circulation. In MSA, chemoreflex responses are blunted. The heart receives erratic signals. Blood pressure may fall rather than rise appropriately. The combined hypoxic and autonomic instability creates conditions conducive to arrhythmia. Nighttime poses additional vulnerability because parasympathetic dominance increases during certain sleep stages. In MSA, parasympathetic and sympathetic balance is already distorted. A sudden vagal surge during hypoxia may provoke bradyarrhythmia. Conversely, sympathetic overcompensation may trigger tachyarrhythmia. The heart oscillates between extremes without stable regulatory oversight. Sudden nocturnal death in MSA has been attributed in part to this combined respiratory and autonomic failure. Respiratory compromise initiates hypoxia. Autonomic instability prevents adequate cardiovascular compensation. Arrhythmia ensues. The event occurs quietly during sleep, without preceding chest pain or warning. Even during wakefulness, respiratory integration remains fragile. Swallowing dysfunction increases aspiration risk. Microaspiration during meals introduces inflammation and infection into the lungs. Pneumonia imposes systemic stress, further destabilizing autonomic balance. Fever and hypoxia increase cardiac workload in a system already lacking reliable control. Mechanical ventilation or continuous positive airway pressure may mitigate nocturnal stridor or apnea temporarily. But these interventions do not reverse medullary degeneration. They support airflow but cannot reconstruct neural rhythm generators. The underlying structural failure persists. The intersection of respiratory and cardiac control in the brainstem explains why MSA carries a distinctive risk profile. The disease does not attack the heart directly. It attacks the command center that synchronizes breathing and circulation. When these systems fail together, vulnerability multiplies. Nocturnal death in MSA is therefore not mysterious. It is the predictable outcome of progressive brainstem degeneration, affecting both respiratory rhythm and autonomic cardiac regulation. The silence of sleep removes voluntary safeguards. What remains is a compromised automatic system struggling to maintain oxygenation and perfusion without intact neural coordination. This stage reveals the true scope of MSA. What began as Parkinsonism has extended into life-sustaining centers deep within the medulla. The threat is no longer instability while standing. It is instability while sleeping. The heart and lungs are intact. The brainstem that regulates them is not. Why MSA progresses rapidly? Multi-system degeneration without redundancy. Multiple system atrophy progresses faster than Parkinson's disease, not because it is more dramatic at onset, but because it removes structural redundancy early. In Parkinson's disease, degeneration begins primarily in dopaminergic neurons of the substantia nigra. The surrounding motor, autonomic, and cerebellar networks remain structurally intact for years. Compensation is possible. In MSA, degeneration strikes multiple systems simultaneously. The nervous system loses its buffering capacity early in the disease course. Motor impairment in MSA involves not only the nigrostriatal pathway, but also cerebellar circuits and brainstem nuclei. When basal ganglia dysfunction combines with cerebellar ataxia, gait instability accelerates. The cerebellum normally corrects motor timing errors generated by the basal ganglia. If both systems are compromised, errors accumulate without correction. Falls appear early. Recovery strategies are ineffective because no intact parallel pathway remains. Autonomic failure compounds this instability. Blood pressure regulation deteriorates in parallel with motor decline. Orthostatic hypotension increases fall risk independently of balance impairment. A patient may fall not only because posture is unstable, but because cerebral perfusion drops abruptly. Each system amplifies the other's weakness. Respiratory integration also weakens concurrently. Brainstem nuclei coordinating breathing and cardiovascular control degenerate in parallel. During infection, dehydration, or minor illness, the autonomic system cannot mount an adequate compensatory response. Physiological stress that would be tolerated easily in Parkinson's disease becomes destabilizing in MSA. Conduction across long autonomic and motor tracts becomes unreliable. Axons lose metabolic support. communication between regulatory centers falters. The disease is not limited to one neurotransmitter imbalance. It dismantles the infrastructure of neural signaling itself. The absence of redundancy defines rapid progression. In Parkinson's disease, dopaminergic therapy restores balance to intact circuits. In MSA, even partial dopaminergic restoration cannot stabilize cerebellar or autonomic degeneration. Compensation fails because the parallel systems are already compromised. Systemic fragility emerges early. Minor stressors trigger disproportionate consequences. Dehydration worsens hypotension dramatically. Fever increases cardiac instability. Infection accelerates respiratory compromise. The patient's physiological reserve shrinks quickly because multiple regulatory systems are deteriorating at once. Executive function may remain relatively preserved early, but persistent hypotension and hyperperfusion strain cortical networks. Episodes of syncope and hypoxia introduce secondary injury risk. The disease does not progress along a single pathway. It progresses along multiple converging axes. This convergence likely contributes to the shorter average survival reported in MSA, narrowing the margin between impairment and life-threatening events. Rapid progression in MSA is therefore structural inevitability rather than aggressive acceleration at the cellular level. When degeneration encompasses motor, autonomic, cerebellar, stability becomes fragile. The heart becomes vulnerable not because of primary myocardial disease, but because the neural networks that regulate it are deteriorating alongside balance, respiration, and coordination. Multi-system degeneration removes the safety nets that normally prevent minor fluctuations from becoming catastrophic. In MSA, the nervous system is not eroding slowly along one axis. It is collapsing across several at once. That collapse defines the speed of progression and the early emergence of cardiac death risk as a central, not peripheral feature of the disease. In multiple system atrophy, the progression toward cardiac death risk is gradual until a structural threshold is crossed. That threshold is not defined by symptom severity alone. It is defined by irreversible loss of autonomic reflex integrity. When the Baroreflex arc and brainstem cardiovascular centers degenerate beyond recovery, compensation becomes biologically impossible. Early in the disease, autonomic instability is measurable, but partially adaptable. Medications may increase vascular tone. Compression garments may reduce venous pooling. Fluid expansion may stabilize blood pressure temporarily. These interventions do not restore neural circuitry, but they can blunt fluctuations while residual pathways remain functional. The margin of safety narrows, but it still exists. The point of no return is reached when descending sympathetic tracts and medullary integration centers lose structural continuity. At that stage, orthostatic hypotension becomes fixed and severe. Blood pressure may drop dramatically upon minimal positional change, and heart rate fails to respond appropriately. But the central processing and effort response pathways are too damaged to execute compensation. Heart rate variability becomes profoundly reduced. The sinus node operates with minimal modulation. Instead of dynamic adjustment, the rhythm becomes rigid or erratic. Minor physiological stressors provoke disproportionate cardiac responses. A brief episode of hypoxia may trigger sustained arrhythmia because neural buffering has disappeared. Supine hypertension may paradoxically worsen as reflex control collapses. Without balanced autonomic modulation, vascular tone fluctuates unpredictably. Blood pressure may spike while lying down and plummet when upright. These oscillations strain the cardiovascular system continuously, increasing electrical instability within the myocardium. Respiratory and cardiovascular reflex arcs are tightly linked. When respiratory centers degenerate further, central sleep apnea becomes more frequent. Hypoxia occurs without adequate arousal or sympathetic response. In healthy physiology, hypoxia would provoke tachycardia and vasoconstriction. In advanced MSA, bet reflex is blunted or absent. Oxygen levels fall while circulation fails to compensate. At this stage, unpredictability dominates. Cardiac collapse may occur without prolonged warning. There may be no chest pain, no progressive heart failure, no gradual decline in ejection fraction. The structural weakness lies not in the myocardium, but in the neural command system that regulates it. Irreversibility in MSA is not theoretical. Oligodendroglial inclusions have disrupted white matter tracks. Brainstem nuclei have lost neurons. Axonal degeneration has removed pathways required for reflex integration. Regeneration of long autonomic tracts in the adult central nervous system is extremely limited and does not restore functional integration once lost. Even if disease progression slowed, lost pathways would not be reconstructed. Clinically, this phase is characterized by persistent orthostatic hypotension despite maximal therapy, recurrent syncope, severe heart rate rigidity, and pronounced nocturnal respiratory events. The patient may appear stable during structured daytime observation, but physiological reserve is minimal. A minor perturbation can trigger irreversible collapse. The point of no return is therefore defined by loss of reflexive cardiovascular control. Once reflex arcs are structurally dismantled, circulation depends on a fragile baseline rather than adaptive regulation. The heart beats, but it no longer adapts reliably to internal or external stress. This threshold transforms risk from theoretical to imminent. Cardiac death in MSA is not the result of chronic coronary disease. It is the endpoint of progressive autonomic disintegration. When cardiovascular reflexes fail completely, survival depends on stability that the nervous system can no longer provide. At this stage, the disease has moved beyond symptomatic management. It has entered structural inevitability. The neural systems that once stabilized blood pressure, heart rate, and respiratory rhythm are absent. What remains is a heart functioning without command, vulnerable to abrupt instability without warning. The final PHASE, aspiration, infection, and cardiac collapse. In advanced multiple system atrophy, the boundary between neurological degeneration and systemic collapse disappears. The nervous system's failure extends beyond motor control and autonomic instability into swallowing coordination, respiratory protection, and immune vulnerability. These secondary consequences do not represent new diseases. They represent downstream effects of brainstem and white matter degeneration that now compromise survival directly. Swallowing is a complex reflex requiring precise coordination between cortical initiation, brainstem pattern generators, cranial nerve nuclei, and respiratory timing centers. In MSA, degeneration of nucleus ambiguus and associated pathways disrupts this coordination. The vocal cords fail to close completely. The epiglottis does not protect the airway reliably. Food and saliva enter the trachea silently. Aspiration may occur without violent coughing. Sensory reflexes that would normally trigger protective responses are weakened. Repeated microaspiration introduces bacteria into the lower respiratory tract. Over time, pneumonia develops. Infection increases metabolic demand, elevates heart rate, and stresses a cardiovascular system already operating without stable autonomic control. Fever and systemic inflammation alter vascular tone. Blood pressure may fluctuate dramatically. Dehydration worsens orthostatic hypotension. Hypoxia from pneumonia reduces oxygen delivery to cardiac tissue. In healthy physiology, sympathetic activation would compensate by increasing cardiac output. In MSA, sympathetic denervation limits this response. Respiratory weakness compounds the problem. Degeneration of brainstem respiratory centers reduces the strength and rhythm of ventilation. Secretions accumulate. Carbon dioxide retention increases. Hypoxia becomes more persistent. Each hypoxic episode imposes electrical stress on the myocardium, increasing susceptibility to arrhythmia. Aspiration pneumonia is therefore not merely a complication. It can act as a destabilizing trigger in advanced disease. It accelerates cardiovascular instability in a patient whose autonomic reflexes are already compromised. Even mild infection can tip the balance toward collapse. During this phase, heart rate may become increasingly erratic. Episodes of bradycardia alternate with tachycardia. Blood pressure may oscillate unpredictably. Supine hypertension combined with orthostatic hypotension strains vascular integrity. Cerebral perfusion becomes unreliable. The margin between compensation and failure narrows further. Sleep remains a critical vulnerability. Nocturnal stridor and central sleep apnea persist or worsen. Hypoxic episodes during sleep may not trigger effective arousal or compensatory tachycardia. The combination of reduced oxygenation and autonomic instability creates conditions favorable for malignant arrhythmias. Sudden cardiac collapse in this phase often follows a cascade rather than a single insult. Aspiration leads to infection. Infection worsens hypoxia and hypotension. Autonomic failure prevents adequate compensation. Arrhythmia emerges in a heart deprived of stable neural input. The event may occur quietly, without preceding signs that would predict immediate catastrophe. Importantly, standard cardiac investigations may continue to show structurally normal myocardium. There is no plaque rupture, no myocardial infarction. The collapse originates from neural command failure, compounded by systemic stressors. Interventions at this stage focus on palliation and prevention of secondary harm. Antibiotics treat infection. Feeding modifications reduce aspiration risk. Non-invasive ventilation may support breathing. However, these measures do not restore the degenerated autonomic network. They stabilize temporarily, but cannot reverse trajectory. The final phase of MSA is therefore characterized by systemic fragility. Multiple regulatory systems have failed. Swallowing, breathing, and cardiovascular control intersect in a narrowing window of stability. Each additional stressor accelerates the risk of terminal collapse. Cardiac death in this context is not an isolated event. It is the culmination of progressive autonomic disintegration, respiratory compromise, and systemic vulnerability. The heart remains anatomically intact. The neural systems that protect it have disintegrated. The final phase reveals the full scope of the disease, a neurological degeneration that ends not with paralysis alone, but with loss of life-sustaining regulation itself. Stable aftermath. Multiple system atrophy is often introduced as an atypical Parkinsonian disorder. It is described in terms of rigidity, gait instability, and poor levodopa response. Those features are visible, they are measurable, they are clinically recognizable, but they are not what defines the fatal trajectory of the disease. The defining mechanism is autonomic disintegration. From the earliest stages, Alpha-Synuclein accumulation within oligodendrocytes destabilizes white matter tracts that connect brainstem cardiovascular centers to the spinal cord and peripheral organs. The Baroreflex weakens. Sympathetic vasoconstriction falters. Parasympathetic modulation becomes erratic. Heart rate variability declines. Orthostatic hypotension appears not as a side symptom, but as the first structural warning that reflex control is failing. As degeneration spreads, respiratory rhythm generators within the medulla deteriorate alongside cardiovascular nuclei. Nocturnal stridor emerges from laryngeal motor dysfunction. Central sleep apnea reflects loss of automatic respiratory drive. Hypoxia intersects with unstable autonomic control. The heart receives inconsistent signals. Blood pressure fluctuates beyond normal buffering capacity. Arrhythmic risk increases without coronary disease. In the advanced stage, aspiration, infection, dehydration, and metabolic stress expose the limits of a nervous system that can no longer coordinate circulation and breathing. Cardiac collapse does not arise from myocardial infarction. It arises from loss of neural supervision. The sinoatrial node continues to generate impulses, but the command architecture that modulates it has been dismantled. Irreversibility in multiple system atrophy reflects progressive structural degeneration of affected neural systems. Oligodendroglial inclusions disrupt myelin. Axonal tracts degenerate. Brainstem nuclei lose neurons. The reflex arcs that stabilize blood pressure and heart rhythm cannot be reconstructed once lost. Supportive therapies may slow symptomatic decline, but they do not restore neural connectivity. The structural threshold, once crossed, does not reverse. Cardiac death risk in MSA is therefore not an unexpected complication. It is the predictable consequence of multisystem autonomic degeneration. The heart is structurally intact. The nervous system that protects it is not. When that protection disappears, circulation becomes fragile. Minor stressors become destabilizing. Sleep becomes vulnerable. Compensation becomes impossible. This is not a disease of the heart muscle. It is a disease of the systems that regulate the heart. Multiple system atrophy reveals a fundamental biological limit. Life depends not only on organ integrity, but on integrated neural control. When that integration dissolves across motor, autonomic, and respiratory domains simultaneously, survival becomes precarious even in the absence of primary cardiac pathology. This is pathology of fear, not because collapse is sudden, not because the heart is weak, but because the invisible systems that keep it stable can fail long before anyone expects the final event. And this fear is real.